I'm Dr. Michael DeTola.
And I'm Megan Strong.
In this week's Case of the Week, you can teach an old dog new tricks. I give my first Gow-Gates injection.
And a Croatian woman got a lucky strike that landed her in the dental chair.
Ah, Sweden, land of tiny meatballs, lingonberries, and mediocre furniture that needs to be assembled with an Allen wrench. And prisoners dying to get some dentistry. That and more on today's Chairside Live. Hello and welcome to episode 80 of Chairside Live. Megan, how are you this morning?
I'm doing really well. I would like to wish my mom and dad a happy birthday because today is my mom's birthday. Happy birthday, Mom. And tomorrow is my dad's birthday.
Really?
Happy birthday, Dad. Yeah.
That's interesting. I've never heard about a married couple with birthdays that close to each other.
Same year. And actually only a couple hours in distance apart. My dad was born in Oxnard and then my mom was born in San Jose. Yes, so just a few hours away. And yeah,
wow.
Same age.
Wow, that's impressive. I wonder if that had anything to do with the attraction between them. Like, I don't know if you're into like astrological signs.
Not at all.
So what are they both? What's this right now?
You're asking the wrong girl.
Know?
I have no idea.
Good.
I never have done any of
Glad to hear that. That was a test, and you passed with flying colors. All right, we've got an interesting episode of Chairside Live for you today. In fact, the case of the week is me learning to do something for the first time. You know, I've been a dentist for over 25 years, and it's not often you get a chance to do something for the first time, but I had heard about this great injection. You know, this injection that was so good they never taught it to us in dental school. And when you get out of dental school and you get into a rhythm, you really don't want to experiment with new injections, especially when we're using the longer needle and you're aiming at someone's ear and you're just like, you know, this other one might only work 80% of the time. But at least for me, I was terrified to learn this new one called the Gow-Gates. So I recently had the chance to have a local anesthesia instructor come down here and walk me through it step by step. And I was able to give a couple new injections that I had never given before, the first one being the Gow-Gates. And it worked fabulously well. And really just giving that one allowed me to give subsequent ones without really being nervous about it. I mean, the first couple afterwards a little bit, but it was really easy if you have somebody to do that. I've always wished there was a local anesthesia class like that, a hands-on where dentists could pair up and work with each other, but it's kind of left for us to learn on our own. So hopefully you will gain something from the experience that I went through by watching what we did. So let's go ahead and take a look at that now. All right, Kathy, well, the time is finally here. You're going to walk me through my first Gow-Gates. And let me say before we get started that Dr. Murasan, who graduated from dental school this year and had tuition costs, I'm just going to guess, of over $250,000, $250,000, and didn't learn the Gow-Gates. And as a dentist, you know, here you are at Pierce College teaching the hygiene students how to do it, and you and I, as dental students, didn't get to learn how to do it. So I'm going to make a demand to the ADA that they step in and do this. But anyway, neither of us, I thought maybe just because I'm old I didn't learn it, but she graduated this year, still didn't learn it, so that's fine. So she wanted to experience one, and this will be good for both of us. So how do we get started? What should we do first?
Well, first off is just, you know, switch our thinking from the parallel to occlusal table that we think of for the IA to finding what's going to be your upward inclination. So the area we're looking at is from the corner of her mouth to her intertracheal notch.
Okay.
And, you know, just hold the mirror up there and then just kind of imprint that angle there.
And this is different on everybody? Are there people where it's markedly different?
You know, I think they're generally, you know, it has, you know, a subtle inclination, but this will be specific to her because we're trying to orient to where her condyle is. And this is done with her mouth
closed, not open?
To start with, yeah. Okay. So just start there till you get that, and then just have her go ahead and open wide and see how much it changes. See, it doesn't change much because you're still going to her commissure. Okay. So one of the things I find really helpful is when I'm palpating, is I'll actually put my finger right there, the intertracheal notch, and then as I pull back, then I'm kind of lining my finger up and giving myself, you know, that orientation.
Oh yeah. You're actually kind of seeing that for yourself now with the angulation of your finger.
You know, because otherwise, you know, I'm used to lining up this, so my brain's going to take me here for my standard IA, but I want my brain to go with me up here.
No, I used to actually seem to recall that people actually put their finger in the patient's ear to do it. Is that not really necessary? Or? I'm sure it's not comfortable.
I can appreciate that, you know, that might help them, you know, have a sense of where the condyle is. Same way if you're doing a TMJ check.
But you can't push you're not pushing the condyle forward at all with
and
your
even
finger.
my finger in half, she opens wide. You know, you can feel the articulation, so you're going to feel it move. So I know it's about here. You know, then my next sort of, you know, imaginary thing is then when I turn her back around. Okay, I know where my finger is, and it's going to be a mental image as if I am aiming for my finger, because my finger now is right next to the condyle.
Okay.
So here, over here where I'm moving my finger, that's my target height.
Right.
So where my penetration, I just, let my brain
try to. Yeah, it's kind of like
lock on.
Yeah, it's kind of like just having a finger here, and then you're going to start over here, and you can't see it, so you'd have to turn your head and then try to bring your two fingers together. And you're probably going to get
Exactly.
It's like a roadside sobriety test.
Yeah. The other. So when I come in, I want to choose the height of my penetration in respect to the mesiolingual cusp of the molar.
Okay.
And I'm going to be distal to the second molar.
Okay.
Still, I'm coming in over the bicuspids.
Okay.
Penetration will be there. Open as wide as you can for me. Slightly uphill inclination, and again, as if I'm able to track towards my finger that's palpating on her condyle.
Any idea why you would use the mesiolingual of the first molar versus the second molar, since you're back behind the second molar? Is it
has to do with how the height of the condyle.
Okay.
Because if I'm using a tooth up higher, I'm going to be higher. If I'm using the tooth down lower, so that gives me a line with the height of the condyle.
Okay, sounds good.
And I'm coming out over here. The one other thing that sometimes we use to our advantage is if you look at the flare of her tragus right here, and hers is fairly smooth. It just flares out just a little bit. But if someone has quite a bit of flare out, that can have to do with how far out their ramus flares. So if they have a very narrow chin, then the tragus may be tucked in. If they have a fair amount of flare, so that's going to help me decide how far over in relationship to the bicuspids I'm going to be. If they're going to be really wide flare, then I might be back closer to the molar.
Okay.
If they're much narrower profile, then I may be a little bit closer to the
Yeah, because the wider the jaw is, the condyle is going to be positioned farther laterally, and therefore more flare because of that. And so you would swing around more towards the molars. Okay.
So we get that again, aiming.
And there's probably room to swing over to the molars because of the fact that the mandible's a little wider versus somebody who's got a very narrow one. All right. Sounds good. Well, I guess I get to do a dry run with the topical anesthetic, right? So I'm going to start from over the bicuspids on the opposite side and go to the height of the mesiolingual cusp of the first molar, and then move distal to the second molar and place the topical there. How does that look to you, Kathy, for an
That looks good.
injection point?
Good. And that's a good example how it's not a steep angle up, given how far she can open.
Yeah, I'm looking at that
following,
angle, and it looks
hers.
pretty close to the angle of my finger, like you mentioned before. So.
And it's subtle. It's not drastic compared to your...
It's not pointed at
your
magnetic
alveolar.
north. Okay, so as you mentioned, it doesn't, since we're going to be doing the twizzle that you referred to, and we're going to keep everything nice and straight, it really doesn't matter. It really doesn't matter where we put the bevel, in essence. In fact, we're not exactly sure where the bevel might end up anyway, but it almost doesn't matter because we're going to have it just tracking straight because of the twizzling that we're doing.
And that's going to be, with all the things that we do with the wand, we're doing birotational and...
So birotational, I'm going to grab it a little farther back because it's for a block and not for an infiltration. Okay,
some
Anna Maria.
distance. Okay, how you doing? Right there.
Right here?
Yep, you're good right there. If you can you see that okay?
Yeah.
Okay.
Little pinch here, Anna Maria.
And then just go ahead and start your twizzle whenever you're ready. And just keep your focus on, where that location is near the condyle.
So typically on a Gow-Gates like this, how much of the carpal cath will you take getting back there to your target site?
You've got about 8 seconds before this is going to automatically start into cruise. And I find that that's adequate to get there. And my guess is I'm anticipating you're going to have contact here shortly.
Right there, I do.
Okay. See, and that's about 3/4.
Mm-hmm.
It's traditional for an IA.
And aspirate at this point, yeah.
Correct.
And
from here, things that are
that's
similar.
positive there, so you want me to come back out and...
Let's do.
Okay. How far? Right about here, maybe?
Do you feel you can clear that?
Yeah, what direction would you like me to clear it in?
Just go ahead and do a second aspiration and see if we've got anything.
Well, I'm going to have to...
Okay, that looks clear.
Okay.
Go ahead and go back to site.
With
Yeah, go ahead and just
anesthetic?
twizzle. Yeah, go ahead and advance again. And then aspirate again at your site. And if we're clear on that one, we'll continue.
Yeah, we are.
That looks good.
Okay.
And that's one of the nice things, from this view. You can't see it, but you're clear right from the attachment through the entire thing. So if you have, any positive aspiration, it's really easy to pick up on the wand.
Well, I'm really happy I got a positive aspiration on my first one.
Fun.
A, with you here, and B, just to see how to, just a little nice refresher on how to handle it while you're there. And so typically then for a Gow-Gates, once we're in here and expressing it at the normal speed, you do the rest of the carpule here?
We do a full cartridge.
Okay.
Mm-hmm.
And then that's it, just that one cartridge, and then stay open for 2 minutes?
And the conversation we had this morning, because that the soft tissue space in there will accommodate more. Many people will just choose to do 2 cartridges, which is super, because we would just do our switch out. You'd hold your position, we'd reload at the base of the STA unit, and then go ahead and deliver the second cartridge.
At this point, with me back all the way, would you ever take your thumb and put it on the occlusal table to kind of remind the patient to open a little bit at this point?
You sure can.
But
you sure can.
I feel like if I'm in contact, like I am now, that with her, that she must be open enough if I'm contacting the bone. Is that correct to think that way, or not necessarily? Because I feel like I'm against that part of the
as long as it's not changing your needle depth. If she started to close,
Oh,
and she
okay,
started
got
to
it,
see
got
the
it.
needle sink
Okay.
away from you, then you'd really tell that the condyle is
Okay.
pulling away. But that's not a bad technique to just gently remind them.
I also have to say that this is literally the first time I've ever used a 25 gauge. We were taught all 27 gauges in school, and so that's what I always used. I really like how it felt, and I really like what the contact felt like. We talked about in the interview that little kiss, and that's kind of what it felt like, whereas with a 30 gauge, I could see how it might not feel so definite. Like, it just feels like I have a definite tactile feel because of the larger gauge.
Yeah, in our experiences, patients really aren't able to tell the difference between the needle gauges. And if it's just psychological for us,
right,
and being able to maintain some control in those denser tissues, there's some reasonable logic to that.
Mm-hmm. Yeah, I've seen those studies too where they can't tell the difference between a 25 and a 27. So why would we do it for us if we can give more effective ones? All the patient cares about is being properly anesthetized, so.
And it's our own psychology.
Do you ever speed up at all on these injections, or are you very patient with these? Or maybe if you saw a patient starting to close and having trouble staying open?
I tend to stay with the normal rate on these. I know that there's a turbo, but it's like, if you think about injection hydraulics, and the smaller the gauge of the needle, the higher the pressure will be at the needle tip. The faster you expel, the greater the pressure. So if you just think about your garden hose, putting your finger over it and creating a spray when you're washing your car.
Right.
We speed up, we use smaller gauges, and we're putting out a lot of pressure right at that needle tip. And the whole mechanism of paresthesia, they don't know.
Right.
It's a combination of things, and certainly the injection hydraulics has been discussed and looked at and can be part of that whole mechanism. So I think if we can control any of those factors, why wouldn't we?
Right. All right, there we go. That Jamaican drum tells you that we're done. Guess that you don't need to buy rotational on the way out, but it was fun to do.
It's fun to practice it again.
Wow, now if you would, I remember from you telling me this morning that we want the patient open for 2 minutes, so Anna Maria, I'm going to make it easy for you. There you go, just relax against that. Oh, perfect. And I will start the clock for 2 minutes, and we'll see if we have any anesthesia by the time that 2 minutes comes around. All right, it's been 2 minutes. I'm going to go ahead and remove that. You can go ahead and close, Anna Maria. Actually, it's been a little more than 2 minutes. Let me ask you, and I want you to be perfectly honest unless it's an answer I don't want to hear. Are you starting to get
upper and lower?
Upper and lower. Kathy, what does that mean? Was I in the wrong spot?
If she's upper, remember that the maxillary branch of the trigeminal nerve is going anterior about the same point that the mandibular branch is dropping down. So when we're at that height, we can definitely get collateral anesthesia. People will often have their auriculotemporal nerve also anesthetized, so not at all uncommon to have the ear feel some numbness too.
If you ever would like to be the recipient of a Gow-Gates, you just let me know and
I'm okay, thank you though. I appreciate that. Okay.
Your call.
Now let's go to a segment we call Viewer Mail. This week's Viewer Mail comes to us from Ukraine. We've got an international letter, and it comes from Michael Slipka. I hope that I pronounced that correctly. I probably did not. And he is the past president of Ukrainian Dental Students Association. And he writes, "Hello, I am grateful for your educational work. I tried to reverse prep when I was in my 3rd year in dental school and found out that dentistry could be easy. And now I have graduated and make many efforts to tell dentists and patients about high-quality dentistry. My question is about ferrule effect. How can we use it to save the tooth? With respect, Michael."
Well, Michael, that's great. Thank you for taking the time to write to us from the Ukraine, and you've already cut me off at the pass for my first question, which is how to pronounce my name, Michael, in Ukrainian. Apparently, it's Michael. That's not as dramatic as I thought it might be. Second of all, just to let you know, we spend a lot of time here in the United States educating patients about quality dentistry as well. I could see maybe you would think, oh, in the U.S., everybody just walks in and says, give me the best dentistry, give me veneers or whatever. But believe it or not, we do spend a lot of time, just like you, educating patients about quality dentistry because they typically want to go, think they can do something small, like a filling, even though the tooth's had 6 fillings in it before and they don't want to have a crown. So we do a fair amount of education as well. As far as ferrule effect goes for saving a tooth, we always want to make sure that we do have some ferrule effect. So if I've got a tooth that's broken off at the gum line and I'm going to put a core and a post in, so if I'm going to put a direct bonded composite post, for example, and then a dual cured composite buildup around it, if I prep that tooth and all the margins are on the core itself, that's not really good. We've got a possibility when the patient goes into protrusive on that tooth of snapping that post, more likely than pulling it out. We really want to be able to grab on to some tooth structure, as you said, to create that ferrule effect. And so there are times on a case like that where I'm either going to have to do crown lengthening or send that patient to a periodontist and have him do some crown lengthening because otherwise we're not going to be able to get any ferrule effect. At a minimum, we'd like 1 millimeter, but I really prefer 2 millimeters. And so I'm okay with it. I've seen enough teeth break like that. I'm okay with prepping the crown, putting a temporary on, sending it to the periodontist, having them give me, 3 millimeters between where my proposed margin is, or I might even drop the margin down subgingivally if I know the patient's going for sure, and then have them drop the bone back 3 millimeters from where the new height of the tissue is going to be. So there are times where we can establish it just by putting a subgingival margin and grab onto a little bit of tooth. But there's times when doing that would create a biologic width violation, and so we do need to do some crown lengthening, but it is very important. I've seen too many times where I have disrespected that law of 1 to 2 millimeters of ferrule effect, and the patient has broken the buildup off and snapped the post, or it's just back in the days of metal posts, it would bend and then just debond and come out of the tooth. So it is very important, and thank you so much for taking the time to write in from the Ukraine. I feel like as he's writing in from a former Soviet republic that we should send him something special as a prize.
I absolutely agree, and I've got just a thing for you, Michael.
What's that?
How about this new prize? A Chairside Live 30-piece puzzle.
You must not think much of our dentist.
No, listen.
30 pieces is not much, is it? That sounds to me like a...
There's a lot of black here. You never know.
Oh, that's true. Yeah. I guess that would make up for that.
It would.
Because I grew up watching my dad, do like 1,000-piece puzzles.
Yeah, my mom too. It's weird. But I thought this would be the perfect gift because the holidays are coming up. People are gathering together, and if you want to avoid Grandpa, this might be a good time
to go in the other room and work on the puzzle to
right.
avoid Grandpa.
Yes.
Or would you have Grandpa do it?
Either one.
And take one of the pieces and
pick.
hope he spends 4 hours looking for that piece.
It's rude, but yes.
That is cool. I like that. And then I guess when you're finished with it, you could shellac it.
Please.
Frame it and put it on the
Obviously.
wall. That didn't need to be, that went without saying. I didn't have to say that. Okay.
As I famously say on this show, duh.
And I would like to send to the Ukraine a reverse preparation kit to Michael, because I know he tried it in dental school.
Right.
Which is amazing, because in most dental schools in America, they would never let you do that, to actually try something like that at school, with the exception of Loma Linda University, which lets me come every year and pass out Burkitts to the junior
not
class,
sure how
and
they
then
let
they go
you.
prep.
Yeah.
I don't either, but thankfully they do, and it's an awful lot of fun. So we'll send that to him as well, and that's pretty neat, getting a letter from an international dentist like that.
I like it.
Any news for us today?
Yes. A Swedish inmate recently broke out of jail to go get his tooth fixed. The 51-year-old man fled the prison after guards ignored his request to see a dentist. He had an inflamed molar causing him extreme pain and facial swelling. Once free, he found a dental surgeon who quickly removed his tooth. After the tooth was removed, the man immediately handed himself over to cops and went back to prison. To punish him, they added 1 day on to his month-long sentence. Are you serious?
1 day?
I mean, whatever. He was probably so happy. Who cares? 1 day, add 24 hours onto my sentence. I don't care.
Well, I think they should take a day off. I mean, because it wasn't like if he would have busted out and went to Disneyland, okay,
Sure.
he went in and had dentistry done. That's where I think that should count as 2 days. That's adding insult to injury.
Yes.
Take a day off of his sentence.
And then went straight to the police and said, okay, take me back.
Right, and that's incredible. So obviously he wanted to do the right thing. He
Right.
didn't. He probably had a chance to escape and could
Oh,
have,
I'm
and was
sure.
out of pain now and probably had more energy that he had in like a week.
Right.
So I just don't understand. We have dentists here in prisons, and I've met a couple of dentists who work in the whole California prison system has dentists and hygienists who work in there, because you have to take care of inmates. So I wonder if they don't have a dentist in there, or if he was just booked up. But to break out, this couldn't have been a maximum security prison, right? We're not
Right.
talking Alcatraz.
I don't think so, no.
It's more like the country club kind of ones.
I'm not sure if it was like the Lindsay Lohan type, but I think it was just a little bit lower security. It had to have been. I mean, how would you escape otherwise? But yeah, and I think it's funny. Could you imagine this man just escaping prison and then like, okay, gotta find me a dentist, and like looking around for a dentist to pull his tooth? It's just insane. Wow.
I can imagine being the dentist, though, and if a guy, I don't know if it's like here, where like in California they wear orange jumpsuits.
Yeah.
And like Orange is the New Black, that show, and I don't know if somebody came in wearing an orange jumpsuit, I'd be slightly terrified.
Right.
I'm not sure. I might call the cops, and so maybe this was
And
from
by
a
might
place.
mean you definitely.
We definitely would, yeah.
Right,
Like
yeah.
if a convict walked
Panic
in.
button underneath the desk. Are
Exactly.
you kidding?
You're thinking to yourself, he's here for drugs, he's there for money,
Right.
not he's here for an extraction. That'd be the last. That'd be like reason 87 why he just
Definitely.
kicked in the front door. So kudos to the dentist who did that as well. And maybe he was just dressed in like
Normal.
blues.
Yeah.
Something that didn't look too intimidating.
Sure.
Interesting. Anything else?
Yes. An 87-year-old woman in Croatia says that she has 2 new teeth in her mouth, all from being struck by lightning. The woman says that her dentist confirmed that she had 2 teeth that had never emerged, surfaced due to stress. She says it's from getting hit by lightning in front of her house 2 years earlier. She luckily escaped the ordeal with an injury to her hands and, well, 2 new teeth.
Yeah, I don't know.
Right.
This is one of those only in Croatia things. And this is from the Croatia Times, right?
Obviously.
When you sent me the link. And I do their crossword puzzle every Sunday. It takes me a good 2.5 hours to get through it. And my subscription, because I subscribe here in Southern California, it takes about 8 weeks for the paper to actually get here. Very old news. Don't remember seeing this. And there are times where, as a dentist, even though you know the patient is 100% wrong, just out of their mind, you agree with them, because there's no point. No point in having a fight. It's a lot like being married. You find yourself just going, okay, yeah, no, you're right, and try not to roll your eyes while you do it. You have to sit there and make that compromise, because it doesn't do you any good to convince the patient that they are wrong about something. So I could see somebody telling me, I have 2 new teeth. It's like when pregnant women will say all the time, or not pregnant women, but moms like in their 50s who have lost a tooth or 2, and they'll say, oh yeah, I lost 1 for each of my children. And they're like, that's a thing,
Right.
that you lose 1 for each of your children. And if it's a thing, it's just a wives' tale.
Yeah.
But I don't argue with them and say, well, are you crazy? That doesn't happen.
I might.
argue with them, it doesn't do
Yeah.
any good.
I
You
know,
just-
but then you'd reach a certain point where you would throw your hands up in the air and say, okay, yeah.
That's why you do a show like this, so you can vent all the anger that you have about
Feel
this.
better
And-
already.
Yeah, I think he was just agreeing with her to not make her feel dumb and saying, oh, no, yeah, you did. It does look like there might be 2 extra teeth here. And so if she loses like another tooth or 2, you can't stand outside and wait for lightning. I'd like to see her put her head very close to the microwave and run it on high. And just see, because if lightning does it in a split second, maybe a microwave at 6 minutes.
Maybe.
You never know. Grow a few new teeth for her. But again, it's one of those things. It's like the Weekly World News, my favorite newspaper, and everything that they always report on, whether it's Bat Boy or a Croatian woman hit by lightning grows 2 teeth, it's always in some faraway place where you could never go check up on it. Never happens in Los Angeles or Boston or Chicago. So who knows? Entertaining nonetheless.
Yes.
All right. Thank you for that. That about wraps it up for this edition of Chairside Live. On behalf of myself, Megan, the CSL crew, and everybody here at the lab, I want to thank you for your time and your commitment to quality dentistry.
We'll see you next time. An 87-year-old woman in Croatia says that she has 2 new teeth in her mouth, all from being struck. Sorry.
I'd like to see her put her head very close to the microwave.